So good evening, everyone. My name is Ben Wakely, and this evening it's my pleasure to host another BASH webinar. I can see that people are frantically trying to log into this webinar. I'm going to wait just a couple of minutes as the numbers increase. While we're doing that, I would like to thank my predecessor, Professor Fayez Ahmed from Hull, who's been leading the educational side of things for BASH now for several years, and he's been instrumental in the development of these webinars, which we've all enjoyed over the past few years, and hopefully I'll be able to do half as good a job as he's done. This evening's topic is update on headache therapeutics. And without further ado, I would like to introduce our two speakers, both from King's College London. First up, we have Dr. Philip Holland, who is a reader in neuroscience, and his research is on understanding the underlying mechanisms that increase migraine susceptibility, with a particular focus on the central nervous system. And tonight, he is going to give a talk on current understanding of migraine pathophysiology. Then we have Professor Peter Goadsby, who recently co-received the prestigious Brain Award for his work on calcitonin gene-related peptide and how this molecule can be targeted for the treatments which we all depend on today. Professor Goadsby will talk tonight on CGRP monoclonal antibodies, GPANTs, and other novel therapies in migraine. I'm now going to hand over to Dr. Philip Holland for his talk. Thank you, Phil.
I'll just unmute myself. Thank you, everyone, for coming to listen. I'll just share my slides now so that you can all see the presentation. Can you confirm you can see that, please, Ben? Great. So, good evening. Thank you, everyone, for coming at the end of, no doubt, what was a busy day to listen to the talks. I'm going to give a little presentation here just around our current understanding of migraine pathophysiology. And I'm going to do this in two ways. I'm going to start, as Ben mentioned during the introduction, looking at the central nervous system and the role it plays in migraine disorder, so setting the underlying biology of migraine. And then in the later section of the talk, we'll focus on the anatomy of head pain and take that towards then the discovery of the new CGRP therapies, which of course you'll hear about in the second talk today. So I won't need to cover that in any great detail because you have the world expert on that speaking right after me. So when we discuss migraine, let me just go onto the slide here now, we really think about a lot of focus on the headache, but it's becoming more obvious now that we have this underlying biology, this brain biology in migraine patients, genetic manipulations, genetic predisposition, and changes that's happening in the network. And long before we get this headache phase, so right now in these very early symptoms, 1 to 2 days before the onset of the headache, we have these very early premonitory symptoms in patients. And these can often be things like fatigue, so patients will start to experience excess tiredness, photophobia, polyuria, difficulty in concentration, and things that you'll notice in your patients or they'll report to you before the attack, and often confused with triggers, which we'll come back to in a later slide. In a small proportion of your patients, they'll also have the migraine aura, this cortical event, often visual in nature, but also can be motor or sensory, that happens in about 20 to 25% of migraine cases. And you'll know the characteristic appearance of that in your patients. And you see in the red here now, we have, this is the building headache then. This aura can occur either before or during the headache phase. And then we get this ensuing headache that goes from mild to moderate and up to a severe throbbing unilateral, often unilateral pain in those patients. And importantly for what we're going to talk about today is the localization of that pain to the ophthalmic dermatome of the face. So the first order trigeminal dermatome, which we'll discuss. And then in many of those patients, and we still don't know why headaches stop, why migraine attacks stop, but in many of those patients, after the attack ceases, we have this resolution phase, where again, really the patients report feeling washed out and having these sort of long-lasting cognitive issues, symptoms like feeling difficulty concentrating and having these concerns. So really we're looking at a spectrum that lasts, you know, a number of days in the individual patients, and we're not just looking now at that headache component of the attack. And that's what I'm trying to get across in this talk that we'll be doing here. If we look at this, I took this from the American Migraine Foundation because I thought it was a very nice graphic to show the diversity of the symptoms in migraine. So back here, and our American colleagues call the premonitory symptoms the prodromal phase. So again, we've got things like yawning, fatigue, nausea, photophobia, and phonophobia. So you can see these diverse symptoms. The aura symptoms, again, being these cortical phenomenon that happen because of this cortical spreading depression. And then into the actual headache phase itself, things like throbbing, insomnia, vomiting, nausea, and changes in mood and different things that can happen. And again, then into the post-stromal phase, lack of concentration, fatigue again, and mood changes. So really showing us that there's a huge number of diverse symptoms in migraine, and enough that it suggests that it's not just a pain condition. It's a condition that involves multiple structures and multiple neural networks involved in cognition, arousal, appetite. And we're going to look now at some of those structures that are important for the migraine attack. This is a slide I borrowed from, I think it was Professor Andrew Russo via Professor Andrew Charles, because I really like how it laid out across the attack what we know from human neuroimaging studies. So really showing us that during these early premonitory phases, we have the involvement of hypothalamic and brainstem structures during the attack. We know the aura is a very defined cortical phenomenon. And then into the headache phase, not exclusively these structures, but again, activation now the sensory thalamus becoming involved in attacks and being abnormally active in these patients. Unilateral activation within the brainstem. Great work from Dr. Shazi Al-Fidi showing the unilateral activation within the brainstem to the side of headache. And of course, the hypothalamus remaining active through the headache phase in these patients. And I just took this image from an e-thesis that's available online from Dr. Pierre Bose, who did his PhD with Professor Peter Goldsby, and really showing that actually during the post-stromal phase, there's a lot of hypoperfusion and changes happening within the brain, so reduced blood flow at this point. And this is a phase of migraine that we probably know the least about at the moment, actually, so ripe for future discovery. So what happens in these patients during the premonitory phase? Well, I've entitled this slide Triggers or Premonitory Symptoms, and really because there is some confusion. If a patient comes in and tells you that it was bright light that triggered their attack, it may well be that they were experiencing photophobia in the build up to the headache, and therefore they misinterpreted the bright light as a photophobic experience. But we can see when we speak to these patients, and this was a study by Kelman back in 2007, showing that about 80% of patients report stress as a trigger or changes in stress. Things like hormonal changes, obviously, with the high prevalence in women, not eating or skipping meals, sleep disturbance, but importantly, sleeping too much or sleeping too little. So really suggesting that any change in normal routine or normal homeostatic regulation, so the balance of the body, really is likely to trigger or occur during the early migraine phase. And then there was a lovely study done by Nicola Giffen a number of years ago now, where using an electronic diary, they asked these patients, what are your most common premonitory symptoms? And you can see the most common here was fatigue in almost 3/4 of patients, difficulty concentrating and stiff neck in about half the patients, all things you'll recognize from your patients. But importantly, from a pathophysiology perspective, the key thing is now if you ask those same patients to predict an ensuing headache based on the presence of those features, you can see again that about 3/4 of the patients here can accurately predict an ensuing headache. So really showing that these symptoms are biological hallmarks of the disorder and the ensuing attack. And therefore, it's really important that we understand the structures and networks involved in generating these symptoms. You've seen this image before, but in a much smaller version. This was work done by Farouk Mania and Professor Peter Goldsby. So again, taking patients, triggering a migraine attack in those patients with nitroglycerin, but scanning the patients and looking at the difference between the baseline and the premonitory phase, so before the onset of the headache phase in these patients, and really showing again that these hypothalamic and brainstem structures here are the structures that become abnormally active in these patients. And quite importantly, actually, I think from certainly from my perspective as a scientist trying to understand migraine, is that some of these activations, the paper actually reported, could be linked to the physiological symptoms that the patient was showing. So, for example, occipital cortex activation in people who were reporting light sensitivity. If we think about hypothalamic activation, reporting things like polyuria, mood changes, changes in appetite, all things that are regulated by our hypothalamus in terms of that. And we've done a lot of work around that we won't go into today. But then as we go into the headache phase itself, of course, I showed you earlier the thalamic activation here. So this is the thalamic activation. Again, great work done by Shazia Afridi, and the brainstem activation again from Shazia, showing that during the pain phase, some of these different areas within the brain become active, but some of these key areas like the hypothalamus and the brainstem stay abnormally active in these patients. And again, this is likely now in response to that building pain within the patients and that headache that's happening. But again, pointing out important networks that play a role in regulating migraine biology more than just headache and the headache symptoms. So to end that quick whirlwind tour of sort of CNS and brain structure, I think it was good to put in a nice overview slide that just gives an idea of what we mean when we talk about the migraine brain. Well, we're talking about a dysfunctional sensory integration. Migraine is a disorder of altered sensory perception in that way. And within these brainstem networks, we have, here's the brainstem now, responsible for wakefulness, stress response, and of course, modulation of pain. So a key player in the abnormal processing of the sensory information in migraine. The thalamus, of course, is one of the key hubs of sensory information and the main target of our trigeminal thalamic tract in processing trigeminal sensory information, but also involved in wakefulness, sleep-wake switching, and pain modulation. So another really important structure at the interface of migraine. I touched on the hypothalamus a couple of times. As you may have noticed, it's a particular interest of mine, how the hypothalamus controls or regulates migraine biology, especially in the context of sleep-wake patterns and circadian rhythms. So thinking about, for example, cluster headache as well, where the patients show very clear circannual periods of attacks. And how can we understand that then? In order to do that, we have to understand the biological clock of the brain, which is in the hypothalamus, this key nucleus here that drives our biological rhythms. When we think then about other aspects of pain, so the episodic and emotional memories and stress response, of course, we can't rule out structures like the amygdala and hippocampus play a really important role in these pain networks and are likely play an equally important role in migraine. And of course, either in the context of migraine aura, but just in the context as well of abnormal functioning within the cortex, again, changes in attention, cognition that can happen through these cortical changes and the sensory integration of that information ascending in this trigeminal tract. So that was what we wanted to cover at the start now, thinking about the brain. But what now happens in the context of headache? So what do we understand about the anatomy of headache? And how does that tell us about the novel therapeutics that we've come to appreciate so much these days? Actually, it's when I joined the field, so it was very much in the early days of the CGRP development. For those of us in the field now, it's now very much a mainstay. Of course, some others it's still very novel. And really take you back now to the really early 1900s, so this 1934, 1935, 1940 here, and some seminal work done in humans during awake surgeries, where we were able to stimulate intracranial structures like the meninges and things around the blood vessels, so the areas of the brain that are innervated by these nerves. And the patients, when we do that, the patients reported this referred pain in different regions depending on where you stimulated. And importantly, as you can see here, depending on where you stimulated, some of this pain is referred to the ophthalmic dermatome again, so this first division trigeminal nerve, where the patients are reporting the majority of the unilateral throbbing pain. And this is actually an image from one of the original pieces of work. And you can see, depending on different regions here, so stimulating here near the sinus or lower down here, you can see that again, this pain is reported around the ophthalmic dermatome, but can also be lower here down toward the neck. And you can see again, in some cases, across the entire face. So referred pain from stimulating these intracranial pain sensing structures that was referred to the face in these patients. And that really gives us a clue to the nerve structure and the anatomy that underlies this sensation of referred pain that our patients are reporting. And it's a good point to pause here, because we've just been speaking about stimulating around the blood vessels of the brain and really touch on the vascular theory of migraine. And hopefully now everyone very much understands that migraine is a neurovascular disorder. But just to highlight that point, this was a really important study done in 2013, showing that really in migraine attacks, there's very little vasodilation happening here. So suggesting that vasodilation, as was initially thought, is not a driver of the migraine pain. And one of my favorite studies, actually, I still come back to this study. It's a remarkably simple study, but a remarkably eloquent way to answer the question. If the throbbing and pulsatile nature of migraine was due to cardiac output, so in this case, heart rate, then the throbbing should in some way correlate with cardiac output and heart rate. And this was a study done some 10 years ago now, actually, to measure that. And essentially what you can see here, this is the important graph. You can see in blue, this is the throbbing rate that the patients were reporting. So they're tapping this throbbing rate out and the frequency is recorded versus their heart rate. And you can see that these are occurring at completely different frequencies. So there's no correlation at all between the cardiac output and the pulsatile nature of the migraine pain. And I won't go into great detail on this. Well, I won't go into any detail actually, but we now understand that there might be specific pacemakers within the central nervous system that are actually involved in making these rhythms that drive that pulsatility of pain. That's a whole other discussion for a whole other day. So building on that work, obviously this is where we start to get into the CGRP story. So this was an adapted graph from some of the seminal work by Professor Peter Goldsby, Lars Edvinsson and colleagues, and showing that during a migraine attack, if you measure jugular blood and look at plasma CGRP levels or serum CGRP levels in these patients, what you can see, here's the control patients here, and in black is the migraine patients. You can see that you see this significant increase in CGRP release and PACAP, this pituitary adenylate cyclase activating polypeptide. But we'll focus on CGRP for just now. So during a migraine attack, we get this release of CGRP, this really important neuropeptide that we've all come to know and understand. So really that led us to think about, or led them to think about, well, what are the innervations of these peripheral meningeal structures and these peripheral afferents from the trigeminal nerve? And of course, in black here, we have the trigeminal nerve signaling through the trigeminal ganglion, TG here, and it expresses CGRP, substance P, which many of you will know failed for migraine therapy trials, and this PACAP molecule here, which is still under development as a novel therapeutic for migraine. If I was talking to you tonight about cluster headache, I would be very focused on this phenylpalatine ganglion here. So this cranial parasympathetic output that we know is responsible for the cranial autonomic features in, say, cluster headache, but also in those migraine patients that have these cranial autonomic features. And again, the superior cervical ganglion here with noradrenaline and neuropeptide Y signaling. So now focusing in on this trigeminal ganglion here, which expresses the CGRP, which if you remember is released in patients, has really took it towards the next step in understanding how this might be involved in those attacks. So this is the trigeminal nerve here. Some of you may know this is the three divisions. So we have the ophthalmic, the maxillary and the mandibular. So two sensory, the ophthalmic and the maxillary, and the mandibular being sensory motor function. And importantly, when you look at this nerve, of course, in relation to CGRP therapies, within the trigeminal ganglion here, for example, these CGRP peptides are expressed. And other work has shown that the receptors are also expressed here that respond to this. So CGRP is expressed within this pathway, and we've seen already that it can be released during an attack in patients. And the central then projections of these pathways into the spinal cord, this is a rodent image here, and what you can see is here, these red are these CGRP afferents terminating in the spinal cord now, where that sensory information has then been relayed on to the brain and to the higher structures such as the thalamus that we spoke about in the early part of the talk. And this is now a very similar slide to what you saw with humans, but this is now the work by Professor Goldsby and colleagues where they stimulated now the trigeminal nerve in animals, in this case, to see if they could recreate that release of neuropeptide. And indeed, when they stimulate the trigeminal nerve, what you can see here, again in black, is this release of CGRP in the stimulated animals versus the control, and quite a large increase in PACAP actually compared to the control subject here. And again, no change at all in substance P. So really mimicking what was seen in the clinic. So it gives us validity in terms of modeling the disease, but also speaks to the therapeutic predictive nature of this, where substance P therapies failed for clinical trials. Of course, CGRP therapies have now been approved for clinical trial, and we'll hear about that for patients. And PACAP is still very much under development for a novel therapeutic target. So where does this put us in terms of the brain? Well, this puts us in the context of, as I mentioned, migraine being this disorder of sensory integration. So we have a central nervous system network that, for genetic and other reasons, has this episodic abnormal activity and activation and changes in network activity. And onto that network activity then, we now feed this incoming peripheral sensory information from the trigeminal nerve in this case. And of course, that sensory information is then misprocessed as being painful, or normal activation either being perceived as painful, or of course increased activation through peripheral and central sensitization, driving more of a pain phenotype in these patients. So we have this vicious circle almost, where we have this afferent pain information coming into a sensory network that's disrupted, and therefore results in a dysfunctional processing of that sensory information and a dysfunctional response. So really then we were interested in some work in understanding, well, where might CGRP be working? How might CGRP therapies be working in these patients? And this was a very early study done by Dr. Robin James Storer in the laboratory of Peter Goldsby. And essentially this was done in animals, but he was recording here now within this trigeminal cervical complex, this main interface for this incoming trigeminal peripheral information. And this is what it looks like in the animal model here. So you're stimulating the afferent fibers here by driving this pain pathway. And then you can record here within the trigeminal cervical complex and look at neuronal responses. And when Dr. Storer did this, here's just an example. So in this case, he was responding from a cell here that conveys trigeminal sensory information, and he was pulsing glutamate, so an excitatory neurotransmitter, to activate these cells. And you can see that they become nicely active to the glutamate pulses. But when you're on to for bibbin, and some of you may know this now as okegepant, so one of the first GPANs that was stopped because it was only available as an intravenous molecule in terms of its clinical development. You can see when he iontophoreased bibbin, so okegepant here, the CGRP antagonist, he was able to inhibit this response. So really showing proof of principle, very clear evidence that by blocking CGRP signaling here, you can block this influx of peripheral sensory information to the central nervous system from the trigeminal nerve. And just to touch on a couple of other studies, this was work done in the laboratory again by Patricia Pozo-Rusock, who again was working with ourselves and Professor Peter Goldsby at this time, and using a very similar model here now, where she recorded in the trigeminal cervical complex to see these neuronal responses, but this time injected CGRP and different molecules within the periaqueductal gray here in the brainstem. So this was one of those key areas that lights up and is activated during the migraine attack and during the early premonitory phase. And if you use CGRP in this structure to manipulate its signaling, what you can see here in red is when you give anything above the line means it's pronociceptive, so they induce more activation of this pathway, so more pronociceptive and likely to induce more pain. When you inject CGRP into this structure, you really heighten by about 30% this nociceptive response in the animals. But when you give either this okegepant here, the bibbin molecule, CGRP antagonist, or a truncated CGRP molecule that also blocks the CGRP receptor, you can actually then inhibit that pain response within this structure. So really showing that at different levels of the nervous system, CGRP could be working to modulate trigeminal pain. And as you can see, it's always good to look at the control animals, and you can see here in control, nothing at all, so no change at all in that pain processing. So how are these therapies working? Where are they working? Still up for debate. Of course, we can have a discussion later about blood-brain barrier permeability and different things. But really, I borrowed this slide, and let me just bring up the reference, so you can see. I borrowed this image here because I thought it's a really nice slide that shows the likely modes of action and certainly the location of action of a number of these therapies. In this case, at the trigeminal ganglion. So this is the trigeminal ganglion and the trigeminal nerve here. And the blue circles are the CGRP molecules being released. So the drugs we know, for example, like the triptans, the 5-HT1B, 1D agonists, they act prejunctionally on the nerve to block the release of CGRP. And we understand now from the work that's been done and published that this is also the mode of action of, for example, lasmiditan, the related 5-HT1F agonist. And then we get on to the CGRP therapies, of course, now. In this case, we're not blocking CGRP release, but in the context of the monoclonal antibodies, here down on the left, we're either blocking the CGRP receptor, and this receptor importantly consists of two components. This yellow bit here is called a RAMP, a receptor activity modifying protein, and that's important for changing the function of the receptor and species differences. And of course, the actual calcitonin-like receptor itself, so you can see this green component here. And you need the two of these parts together to get the functional receptor component. So it's this receptor that's blocked by some of the antibodies, of course, or we have antibodies, of course, that actually target the CGRP, the neuropeptide itself, and mop up that CGRP so that it can't act on the receptor. And of course, then the small molecule antagonist, the GPANs here, you can see acting directly on the receptor to block the function of CGRP. So really showing us that where these are likely acting, and importantly, it would be not any great evidence, as I'm sure you'll see from Professor Gosby's talk, that targeting either CGRP itself or the receptor produces any great clinical difference in terms of response, but very important from understanding the mechanisms of the disease. And having discussed the receptor and this receptor activity modifying protein, this is just a really beautiful study done by Professor Andy Russo. So I really like to highlight this work. So we're thinking about migraine, and we've spoken about migraine in the context of pain, but also photophobia and other features that these patients feel. So Professor Russo early on decided to take a mouse, so this is one of our mice here, and he knocked into that mice the human RAMP1 receptor and overexpressed it. So he gave rise to these nesting HRAMP1 mice. So these are mice that overexpress the CGRP receptor. And therefore, they proposed that if CGRP is going to be a really important player in migraine and involved in this pathophysiology, these mice would show migraine-like features from that context. And Professor Russo does a lot of work on photophobia, so he uses these light dark boxes where you place a rodent in the box, and depending on the level of photophobia, the mouse will spend more time in the dark zone, avoiding the light zone and staying away from that. So a very good sort of translational readout actually in the context of the photophobia that you would see in your patients. And under control conditions here, you can see that these mice show no difference compared to their wild type here in grey. However, when you inject these mice with low volume or low dose of CGRP, you can see that these HRAMP overexpressing mice, so these mice that have this greater expression of the CGRP receptor, become highly photophobic. So they have this huge photophobic response to CGRP, suggesting that CGRP might not just be playing a role in the pain of migraine, but may be involved in other features that we've spoken about, photophobia, for example. So just to summarize the last 2 or 3 slides now, showing that this trigeminal ganglion here is a potent structure for the mode of action of a number of these novel therapies, being that it lies outside the blood-brain barrier. But we've shown some work tonight showing that within the trigeminal cervical complex here, if you get these molecules here, they can block trigeminal nociceptive transmission. I mentioned the work about the periaqueductal gray, showing that there are CGRP receptors here and it can modulate trigeminal pain processing. And while I've not shown that work, we also have studies showing that this can happen at the level of the thalamus, and more recent work from Professor Andy Russo's group showing that again, even in the cerebellum, may be a key player for CGRP responses in migraine. So we have to start thinking about different structures and different locations that may be involved in the migraine attack where CGRP is pointing us to. And finally, how does this look then in terms of CGRP and what's happening in CGRP? We have the normal case here, so we have normal CGRP, and again, the brain is functioning normally in these patients. During an attack, we know that CGRP has been released from the very early seminal work that led to the brain prize that we were discussing earlier on in the introduction. And you can see then that in these patients, we then get this high level of CGRP, this increased response, increased nociception, and can lead to, for example, enhanced responses to light, certainly in the case of those mice with the increased CGRP receptors, which would result in this photophobic phenotype. So we have this increased response in the brain, increased CGRP signaling in the trigeminal nerve, feeding into a dysfunctional neural network within the brain, which as having this abnormal sensory response. Thank you for listening. I hope that was not too detailed. I tried to not go into too much detail on some of the aspects. And just thank you to some of our group members here. This is our current group members, key collaborators, including Professor Peter Goldsby and Dr. Jan Hoffman, who I work very closely with, and some of the past members who have now moved on. Just a wee plug for anyone who's not attended. We just had the Migraine Trust meeting recently in London. It's a great meeting, and maybe you should, would like to come along next year and join us for the MTIS meeting. It's a very enjoyable educational meeting. Thank you.
Thank you very much, Dr. Holland. That was a great talk. I'm now going to hand over to Professor Goldsby. There will be some time for some questions at the end. If people can just enter the questions very briefly into the chat box, I'll then go through them and vet them, and I'll pick out some interesting questions for a 10-minute session at the end. Okay, thank you very much.
Right. Hopefully I'm on. Excellent. Thanks for asking me to speak. I will offer the shout out to Faiz Ahmed. Only to say that it's hard to think about education without in Bash without Faiz. He's done such a great job in the last few years, few too many years, I suppose. I was asked to talk about CGRP, to say something about the monoclonals and the GPANTs, and to mention some other novel therapies. And I took the brief to be very focused on the clinical side, because as you've just heard, Dr. Holland has quite expertly and thoroughly set out the basic science thinking that's evolving around understanding the pathophysiology of migraine. So I will restrain myself from discussing that in any sort of depth. These are my disclosures, which I've had up just for a minute there while I was riffing, which outlines various people I've spoken to in the last 3 years, and in parentheses is the particular thing that they're interested in as far as in any public domain setting you might think about. I've greyed out the patent arrangement we had with the Neura because the Neura went broke. So it's hard to have a patent arrangement with someone who's broke, but life's a complex thing. I won't be saying much about neuromodulation, so it shouldn't affect things. Dr. Holland finished up by showing these targets in the same sort of a way, so I don't need to labour it. I will say that I think the idea that it's all understood how these drugs work and we could stop thinking about it is a very dangerous idea. That's what happened with the triptans. They were announced as vasoconstrictor drugs. Not everyone, but there was quite a considerable push for people to just accept that that was true and get on with it. And that turns out to be wrong. It's certainly very narrow. And I suspect that the same will be with the CGRPs. We haven't resolved finally where the triptans work, so I don't see any reason why people should suddenly jump within a year or two to decide they've understood how the CGRPs work, because migraine is complex, as Dr. Holland said. And again, the scaffold he discussed of the trigeminal system. So I'll move to talking about some acute therapies. This a little bit is a shopping list of things you could do. Some you like, some you probably don't like, some you wouldn't use. We don't use, well, we don't generally prescribe rectal sumatriptan as an example, but it's popular in some parts of the world, and there are various formulations of triptans. I'm not going to specifically address the ditans, happy to talk about them, GPANTs, and just touch on one thing in the pipeline, and then move into preventives after that. So this is the roster, you might say, the roll call for the GPANTs. Given what's been said about CGRP being involved in migraine, the test of that hypothesis was the one on the most left, Olison and colleagues in the New England Journal, which was an up-down placebo-controlled study of an intravenous compound called Bibin 4096BS, which is now called Olsegipant, as all the stem names roll out, and it clearly worked. And one of the more interesting things about these, I think about the field, is when things work, they work, and they work very reliably. In contrast to things that don't work, they tend to fail at the first hurdle, and that's quite helpful intellectually. Dr. Holland mentioned substance P, neurokinin 1 receptor antagonists, and there's half a dozen other examples of interesting things which feed into the research side. All of the other of these mentioned are oral, with the exception of far one on the right, zavegepant, which is an intranasal gepant that's being developed as an acute migraine therapy. Light blue is placebo, yellow is the gepant, and there are 3 greys on your right-hand side of the dashed line, which are zolmitriptan, elytriptan, and sumatriptan, and they're parallel group controls. It's interesting how those studies are forgotten so often, and it's said by some that there are no controlled trials with gepants and triptans. That's not true. However, not all of them be compared directly with a triptan, and that is certainly true. The ones that have gone forward are rimegepant, which is now licensed in Europe and by the MHRA, and ubrogepant, which is licensed in the US and some other parts of the world, but not licensed in Europe. Telcagepant failed. Telcagepant never failed, or 3207 never failed actually in terms of efficacy, but they had an adverse event problem. I'm going to return to that because it's the Phoenix which gave birth to the monoclonals. These are the data for rimegepant. It's a somewhat busy slide, but it illustrates pretty much all the, in principle, things that have been said about rimegepant or established about rimegepant in the last few years. There are 3 studies that are cleverly named 301, 302, and 303 because they're phase 3 studies. The first 2, 301 and 302, with a tablet. The third is with what's called in the US the orally dissolving, or ODT formulation, and in UK is to be referred to as the oral lyophosylate, apparently. You can see the results are more or less the same across all of these, and the dosing is 75 milligrams, which is the single dose that came out of that phase 2 study that Marcus set out that I just had on the previous slide. On the right side of the slide is most bothersome symptom. This is the concept that a patient says nausea, photophobia, or phonophobia is the thing that bothers them the most, and that needs to be gone at 2 hours. It's the FDA endpoint. Again, was positive. Treatment emergent adverse events, pretty modest. You see 0.8% for placebo, 1.5% for the active treatment. And no CVS problems. Interesting, when it was dosed on an option that gave patients to be able to take it every second day, they saw about a 43%. They thought 43% of patients have a 50% reduction, and this is a little bit where the prevention came from, but it also just came from the intellectually obvious idea that if monoclonals would work, then gepants ought to work, although they were developed as acute treatments. You'll see the half-life there, 10 to 12 hours is quoted. It's about 11, hour and a half, the Tmax. 77% unchanged metabolism, which is quite useful. And other sorts of things which are emerging about this medicine from various early phase studies, like the fact that only 1% of it ends up in breast milk. These are the data for ubrogepant. You could look at the data and imagine that you'd simply just change the name at the top because the results are more or less identical. There are 2 phase 3 studies, Achieve 1 and Achieve 2, that are published now. And the results are more or less identical because they're all CGRP receptor antagonists. And there's a fidelity to the clinical trial results. This is right across it's one of the themes of the area, I think, and that's because the target is known for the first time in prevention, and indeed the target is very clear here. So that I think it's notable, the sort of boredom of them being all the same, which I find exciting because it tells you that the results have legs. Same sort of thing, minimal side effects, no hepatic issues, very potent CGRP receptor antagonist, about the same Tmax at an hour and a half, slightly shorter half-life, around 6 hours more or less, and similar sorts of metabolic issues. This is a zavegepant. Won't spend too much time except to say there are phase 2 and phase 3 studies. Phase 3 study was released at the American Headache Society meeting this year. Finally, just to draw attention to the fact that, again, the results look more or less identical to the tablet. There's taste disturbance, of course. You see that in placebo 3.5%, and the Zavegipan disturbances at 13.5 to 16%. Whether patients will find this screamingly useful, we have to say that there's a fidelity to the response is absolutely clear. So we have GPANs coming along as acute therapies, and they're going to be, I believe, available in the UK in December. One of the things that's been crawling around for a long time, and it's not a resolved question, is whether blocking neuronal nitric oxide synthase would be a useful acute treatment strategy. Certainly, pan-NOS blockade. There's a study that Olson and Lassen was the first author published in the 1990s, which was positive, had a few wrinkles around the design. eNOS is not useful, the endothelial NOS, because that creates hypertension. 17%, in fact, of patients in the Lassen and Olson study had hypertension. iNOS is not useful. That's been studied both experimentally and then in a preventive and acute treatment trial, and both of the clinical trials failed. nNOS was studied in a weird way. These people in Uraxon took a molecule to block nNOS and then a triptan-like molecule to block to activate the 5-HT1B1D receptors, and bolted it together, and then did this randomized controlled trial that was negative, which is interesting. It's a very curious outcome. I think part of the problem is the numbers are very small, as you see, and they may have got the dosing wrong. They certainly got the pharmacology and the chemistry right. If you look at there, the behaviour of NXN188 and sumatriptan in terms of the IC50, really very nice pharmacology. They just didn't kind of they may have underdosed, and I don't think I'd have bolted the two together. And in fact, a study was done double-blind in migraine with aura. This study was reported as negative. It's very small, as you see. You put some numbers into that, and again, they might have well got the dose wrong, and the numbers are very small. This is something that needs to be resolved. On the preventive side of things, just moving along to that, we have a range of things that we can talk about, behavioural things that we recommend to our patients that, well, personally, I just regular sleep, regular meals that one ignores, but that's a whole other thing for oneself. All our favourite things there, from beta blockers through to melatonin or memantine or candesartan, which would be my current flavour of the year, so to speak, and the various monoclonals, and I want to talk a little bit about those and the GPANs. Why have we got monoclonal antibodies blocking CGRP? Well, why would someone do that? Well, if you look at the bottom right here, is a study, that randomised placebo parallel group study of telcagepant in the preventive treatment of migraine. And I draw your attention first to the placebo 50% response rate at 22%, and then I ask you to look at the left to the topiramate randomised placebo-controlled trials. These are the registration trials, 22, 23, and 23. They're identical, more or less, the placebo responses. So there's something to be held here. The candesartan study as well, 23%, 50% responder rate. This is a crossover study, two-way crossover with candesartan and propranolol. And look at the numbers, 40% odd for propranolol, 43% for propranolol in the DINA study. I show you those because it tells you, then you look at the bottom at the telcagepant work, 41% for telcagepant given twice daily 140 or 280 against placebo. This worked. It caused 2.5% of patients to have an elevated ALT, and that's moved on, and may well be a bit of bile salt issue. That's a separate thing. But this is the reason monoclonals were developed, because this proof of principle was sitting there and showed that if you block this pathway, you'll be able to have a preventive effect. So it wasn't magic, and they just didn't come out of the air without any thought. This is the receptor structure, and again, Dr. Holland's gone over it, so I won't say too much about it, except to point out this interesting discussion in the literature around the importance of the amylin-1 receptor, which is the calcitonin receptor with RAMP1. Whether that's important, or the extent to of its importance in humans in vivo, I think is an open question. There's some literature, I think rather untidy literature, I would say, which claims that, for example, one of the monoclonals binds to the amylin receptor. I don't think that's got legs in vivo, although the pharmacology is what it is in vitro. It's a very complex complex system. So we have the antibodies, eptinizumab, arenumab, galcanezumab, and fremonizumab, all licensed in Europe and licensed, in fact, in the UK. Slightly variable half-life. But I don't know what to say about the half-life. They're all IgGs because the half-life is measured peripherally, and I don't know what the relevance of that is. If you look at the peripheral, say the forearm model was used for the phase 1 development, it didn't predict things very well at all. Now, one of the problems is it was all done in males, and migraine is substantially a problem that affects females. So we may have got the dosing completely wrong simply by selecting, simply by males being in the studies to start with. And it's something people ought to get a little bit of a grip on going forward, I think. All of the ligand antibodies bind both the alpha and the beta form of CGRP. It's a 37 amino acid with 3 different amino acids between the alpha and the beta form. The alpha form is the predominant neural form, and the beta form, the predominant gut form. None of the antibodies have any discrimination. So it's interesting, but doesn't hit anything clinically terribly relevant. And arenumab binds to the CLR and ramp 1, the so-called canonical CGRP receptor. They're all indicated for migraine in Europe. In the US, galcanezumab is indicated for the treatment of episodic cluster headache. If the European Medicines Agency had had their brain in gear, then that would have happened in Europe. Life can be a complex thing. When you're looking at the studies, they're very similar. Screen baseline for 4 weeks, 12 or 24 weeks, and then quite a lot of variability in how the endpoints were done, whether they were done on the first the last month, for example, in ARISE compared to the baseline, or the last 3 months in STRIVE compared to the baseline, or the whole of the 6 months, for example, for the galcanezumab study. So they're all a little subtly different. What is pretty cool, you have to say, is our understanding of where these things are acting. So on the right there is X-ray crystallography work that John Latham and the colleagues at Alder before purchased by Lundbeck did to look at the structure of the FAB end of eptinizumab and the complementarity determining regions. So these are the regions that lock the target in, so to speak. You see them here in yellow and green and blue and red. And then in light blue or teal, or however you might want to say it, aqua perhaps, there's CGRP. And you can see from the X-ray crystallography actually how CGRP fits in the pocket and gets stuck there. Each eptinizumab is, or it's true of any of the antibodies because of the FAB, and are capable of binding up to 2 CGRPs, although with some trafficking, that it turns out that the number is between 1 and 2. It's not exactly 2. And we know, of course, these things don't have any metabolic immune consequences, because the Fc gamma region has either been altered by 3 amino acids, as the example in the top right there, the reference 7, which is the fremonizumab scaffold. You see the flat line, it does nothing with the immune system, or glycoengineering, altering the sugars in the Fc gamma region, which is, for example, the way the eptinizumab folks put their molecule together. So that there's no opportunistic infection is not surprising and utterly predictable. I won't go through the phase 2 and phase 3 results because because people know pretty much what they are. These drugs work in episodic and chronic migraine. What I think one of the real big learnings that came out of that was the fact that when you go back, there's some work that did on arenumab. It's also been done on galcanezumab. I'm sure it'd be the same for all of them. That when you look at the placebo rates in people who failed previous preventives, they're half or a third of the placebo rate in those who never failed anything. And, we never really ought to have been studying, I suppose, when you think about it, people who'd not had other preventives. That's seemed like a good idea in the past, but I wish I'd never said it was a good idea, because clearly studying people who fail preventives is what we want clinically, and they also drive down placebo rates. And that's been maintained in the phase 3B studies right across aranumab, fremonizumab, galcanezumab, eptinizumab. You see those lower 50% responder rate placebo rates and a decent maintenance of the 50% active rates right across the board for both episodic and chronic migraine. So that's been the sort of table stakes these days for licensing and for particularly HTA reimbursement. What else is happening? Well, Remagepan's coming along. These are the placebo control data to randomized placebo control studies published in the Lancet last year. Particularly note that this drug was given every second day for 12 weeks and then compared to baseline. I showed you the half-life. Not the perfect way to give the drug, he would have said, in terms of the half-life, but that's what came out of the open label extension study that they used to look at the safety. That it works is clear. That probably more people would respond. I won't say better, because everyone who gets a response gets a response. This is a question of how big the population of responders are. And this is the atogepant data. Again, this is with the EMA, and opened the door at MHRA. There are 3 studies. Study 1 and Study 2 are episodic migraine studies. The larger one is the second study that Jessica Olani is the first author on in the New England Journal. You see 29%, 50% responder rate. That's pretty good. I showed you what happened with oral medicines in the 2000s. It's not too far away. And the 60.8% at 60 milligrams once a day. The bottom is the chronic migraine study. This is Patricia Poza-Rosich presented that at the American Headache Society annual scientific meeting. 26%, 50% responder rate, and 42.7 and 41% for the preventives. This is a very well tolerated drug. Mild constipation, for example, about 10%. You see, I've got it there for Study 2 and Study 3. Really quite well tolerated, very simple to use, licensed now in the US for daily dosing at 60, 30 or 10 milligrams a day. So it would be interesting to see how that develops with time. Do these compare with current preventives? This is the Hermes study that was driven by the German government, who insisted on seeing a comparison with topiramate. The end point was actually treatment discontinuation due to side effects. And you don't have to practice very long to realise that it's not that surprising that 40% of people might have discontinued topiramate, and many less, as you can see, 10.6% can discontinue Renyumab. I think you'd find the same thing, whatever antibody you compared it to. And then the efficacy data flips it around the other way, that the topiramate, this was a double-blind 6-month study. So they got tablet and injection, and they're the efficacy data, which is a nice comparison. Are the same things happening in the whole world? STRIVE-1 and ARISE were done predominantly in the US. EMPOWER was done in Asia, the Middle East, and Latin America. See slightly, this is with Renyumab, 50% responder rates. Placebos are higher, and the differences are not much different between ARISE, STRIVE, and these data. This is the 70 and 140 milligram dose, as you can see. So these drugs work all over the world, which is hardly surprising. And this is some data that Moto Khalil put together on our first 6 months experience with these drugs. And on the right is a violin plot, which quite like for non-parametric data. You can see quite see, instead of having the box, which sort of narrows what you can understand about the distribution of the data. There's 2 groups there. I think you can see from baseline to 3 months. There's the people the group at the, you might say the part at the bottom, which is clearly getting bigger. So there's a group of people who are improving, and then there's a group of people at the top for which these medicines don't work. And I mean, that is the nature of things. We saw about a third of patients have some sort of constipation, which is generally speaking mild. And then a really radical sort of thing that's been done with eptinezumab is a randomized placebo-controlled acute study using a 2-hour pain-free endpoint, just as you do for a and most bothersome symptom if you want to license for acute treatment. And it's not licensed that way, and they have no intention of it. But it's interesting when you think about these drugs started as acute drugs, and then because of simply chemistry, the monoclonals were developed as preventives. And if you test a preventive as an acute treatment, well, guess what? You get an outcome. I show you this because this is strategies of care. You see IV withdrawal with aspirin at the bottom. There's Katsarava all those years ago. And on the far right, in the middle is the Danish headache group doing withdrawal plus prevention, a prevention and a withdrawal group. They get very similar results at the end of the day. And on the right is the MOTS study that Todd Schwett led, where they did outpatient withdrawal versus immediate prevention plus a restriction. Tell people to be good. And you see the results at over the first 12 weeks. That was a randomized, open label, but randomized allocation. And what it suggests is pretty much whatever you decide, whatever you can engage the patient to do, that's probably going to work just about the same. And I think there's a general move with these studies to be less dilettante about insisting on withdrawing. What happens when you withdraw antibodies? This is Raffaelli, our German colleagues, because they had to follow rules. And what they showed was when you withdraw, doesn't matter which antibody, arenumab, galcanezumab, fremonizumab, by about 3 months, you're heading back pretty much to baseline, which is greatly disappointing to see that these drugs are, they don't look like their disease, that they're altering the disease in the medium to long-term sense. They certainly keep working. And then there's our American colleagues who rather like putting botulinum toxin and a monoclonal together. And these are some open label data that Laszlo Metzler presented at the International Headache Society online last year to show that you get a cumulative increase if you do both things together. Open label, beware. What's popular now is and increasingly popular is to look at these patient-reported outcomes. One I like the best is PGIC, Patient Global Impression of Change. You see it correlates there. If people tell you they're getting better, unsurprisingly, you can take very fancy statistics and demonstrate that that's correlated with them continuing their treatment, which is hardly surprising. I was going to talk about PACAP and new things, but what I think I'll do is I'll stop there so we can get some questions and turn it back to Ben. And stop sharing.
Okay, thank you very much, Professor Goseby. That was a great run through of all the new therapies which are on their way. We've got a couple of questions. I just want to start off, perhaps with Dr. Holland. Are we pre-programmed to get migraine or not? And why do some people get migraine at different ages?
Yeah, no, so great question. Yes, there is a predisposition there. There's clearly a genetic trait towards having migraine biology. And we see that with migraine, but we also see that with other conditions whereby, for example, people with a migraine biology, for example, are much more likely to experience medication overuse headache, whereas people who don't have a migraine biology but overuse, for example, certain non-steroidals are less likely to or won't develop that medication overuse condition. So clearly there's an underlying biology there. I guess one of the most obvious reasons why different people get it at different ages is, well, in some case, puberty, because we know pre-puberty, it's 1-to-1 relative ratio between male and females. And then post-puberty, that number rises significantly in females. So we get this much more increased prevalence. And again, I think of migraine like a cyclic threshold disease. So rather than when people get it onset, because that might just be a certain number of environmental factors, but why do some people get 3 attacks a month, other people get 10, other people get 15 attacks per month? And we know some of those features, but again, it might just be that through a different association of factors, and some of these will be clinical things that you can look out for, like sleep patterns, work patterns. If you're working night shift, for example, we know that can predispose you to get chronification of disease. So in that condition, you might want to look at obvious lifestyle factors, but then obviously there is clearly a genetic component that pushes you towards having those, probably the age of onset as well, depending on how much load you've got, for example, to push you towards having those migraine attacks.
Okay, thank you very much. And one for Professor Goseby. So this is a burning question that both physicians and patients have, and that is when CGRP monoclonal antibodies fail, why is that? Is that something to do with the biology? Is it something to do with the way that that individual processes the immunoglobulins?
Well, fail's a complex thing. To avoid giving you a straight answer, when you say fail, if you mean fail one, then we will try them on a second one, and about a quarter of people will respond to a different one. Part of that, I think, is that some patients will take simply longer to respond. It'll take longer than 3 months, and I don't understand exactly why. But part of that will be, if you swap, it's just a continued exposure to the mechanism. One of the things which change things is that they may respond if you continue to treat because of natural history again, because they actually are getting better. But I will take responsibility for it. The other thing, so this monoclonal fail is complex. Then there's, have they had eptinizumab, the intravenous version? Why do I say that? Because it's capable of providing a plasma to something else to other compartment gradient. The subcutaneous ones, I don't think can. And certainly colleagues in the US have, I think, utterly convinced that there is a group of patients who respond to the intravenous version and not to the subcutaneous version. And I think that's about where the drug gets. So that's, second level failure is how have you pushed it. And then third level failure is, colleagues will tell you also that the GPANs, and it's particularly true of atogepant, when you can give it to people who failed all of these preventives and it works. And again, is that natural history? Is that a dosing issue? Is it that atogepant will squirrel its way into places that the monoclonals aren't getting? So firstly, there's what's failure mean? It's the same with the triptans. Fail an oral doesn't mean you fail injection. But let's assume that there's a group of people who have, whatever you do, you can, almost give it intracerebroventricularly and it's useless. They're the group of people for which we need new therapies, is why people are exploring PACAP and so forth. I suspect that just as there are patients who'll come in and tell you that light bothers them and it's horrible and they want to have sunglasses on, and someone will walk in and say, no, it doesn't bother me at all. And they haven't read the textbook, which is irritating, but it's not a homogeneous condition. And just as it's not homogeneous, I would expect from that CGRP blockers is not going to work for everyone. I wish they did, but I just think the biology is more heterogeneous than that.
Another question that cropped up is, we know that CGRP is obviously heavily expressed in blood vessels in the periphery and in the gut. Do you think that with the benefit of time, we'll learn more about whether or not these drugs potentially have a cardiovascular risk in terms of increasing ischemic heart disease, cerebrovascular disease, etc., just given that there are a few case reports of people with Raynaud's phenomenon not doing very well, and so it clearly does do something to peripheral blood vessels.
Well, with time, we'll learn a lot of things about these medicines. I doubt whether we'll learn something cardiovascular as in coronary, because of the class of this peptide family, adrenomedullin is much more important in the coronary circulation than CGRP is. That said, there'll be some person in the world, maybe there'll be a lot of them, for whom CGRP happens to be really important, but it's not going to be the majority because that's not what the biology would tell you. The bigger concern will be around stroke because the trigeminal system, part of its purpose, physiological purpose, is protective and reflexly protective in threatened situations in the cerebral circulation. That said, that'll be an issue with very much older people because the demographic of migraine is not a stroke demographic, by the by. So will we learn things? I think we already know that we should be, from what we know already about the biology, that we should be cautious in particular situations. Whether we learn about new situations, I don't know, but certainly for the cerebral circulation, one is careful. For the coronary circulation, one's always careful, but the biology suggests not to be overly worried about it. And for the rest, we will find out with time.
Excellent. I have so many questions to ask about this, but unfortunately time has beaten us this evening. I'd like to thank both of you, Dr. Phil Holland and Professor Goldsby, for your excellent talks this evening. I think we've all enjoyed them and we've all learned a lot from them. And hopefully we'll be able to invite you both back in the future to give some more talks once you have more data and more interesting things to tell us about migraine. Thank you very much.
There's always interesting things to say about migraine.
We've got plenty of data.
Thank you.
Okay, thank you both. Bye.
Take care. Cheers.
Bye.